Hello, my name's Miranda Lomer. I'm a consultant dietitian in gastroenterology at Guy's and St Thomas's in London, and I specialise in the dietary management of irritable bowel syndrome and inflammatory bowel disease. I also have a academic post at King's College London where I'm Professor of Dietetics in Gastroenterology, and this is where I teach dietetics and also have a research team focused in dietetics and gastroenterology. This talk today is going to cover lactose intolerance, and I'm going to give you some insights and some management strategies. These are my conflicts of interest. And in terms of the talk, I'm going to explore lactose digestion mechanisms, focusing on lactase enzyme function in the small intestine, explore the lactose intolerance, covering its prevalence, symptoms and diagnostic methods, look at the dietary management options such as the low FODMAP diet and induction of tolerance through continued gradual increased lactose consumption, and also look at some of the misconceptions around lactose intolerance. This picture here in the middle you can see is of the Houses of Parliament, and this is directly opposite St Thomas's Hospital. I've been at St Thomas's for over 30 years, and you can probably understand why with such a fantastic view. So lactose is a natural milk sugar. It is a disaccharide exclusively present in milk, and it's about 4.6% in cow's milk, 7% in human milk, and it's used as an energy source. It's also found quite widely in the food industry, so it has lots of other properties that enables it to be a sweetener, a taste enhancer, a gel former, a filler, stabilizer, colouring agent. It helps to add structure, and it's also used as a preservative. Milk is a unique feature of mammals, and it's the female that has mammary glands that produce milk for feeding their young. And the lactose is broken down to galactose and glucose, which are rapidly absorbed through the brush border of the small intestine. And this occurs in the majority of mammals. Some mammals have a higher quantity of fat in their milk as opposed to lactose, and this will give them a more concentrated form of energy. So as you can see from this, there are certain mammals that have very low lactose content, and the human actually has the highest lactose content here. As I mentioned, lactose consists of galactose coupled to glucose via a specific type of bond. It's the beta-1,4 glycosidic bond, and this is broken down by lactase, which is the enzyme, and as I said, it's broken down by lactase, which is which is a part of the lactase fluorescein hydrolase enzyme. And this happens in the small intestine, in the brush border of an enterocyte. And expression of this is most profound in the jejunum. And it's particularly important that we understand that during weaning is when you express the lactase enzyme the most, and after weaning this is when we get this gradual decline, and this will impact whether people become lactose intolerant or not later in life, and I will come on to that in a little while. So you can see here from this figure Within the intestine, you've got the lactose, which is being broken down by the enzyme lactase into its constituent monosaccharides, glucose and galactose. These then get absorbed across the enterocyte into the bloodstream. From here, you have the different transport systems, the SGLT1 in orange, which transports glucose or galactose via the facilitated diffusion from the intestine, depicted in yellow across the enterocyte into the GLUT2 blue glucose transporter 2, and this transports the glucose and galactose into the bloodstream as shown here. As I mentioned earlier, lactase production decreases after weaning, and this is an ancestral trait for the majority of people. Almost all mammals, including the majority of humans, about 65%, experience a 90 to 95% decrease in the production of lactase after weaning. And this is known as lactase non-persistence, or LNP. And LNP individuals become lactose malabsorbers, and they can suffer from lactose intolerance, which is what I mentioned earlier. And it means that they have a compromised ability to consume milk and dairy products into adulthood. However, not everybody with lactose malabsorption develops symptoms of lactose intolerance, and hopefully by the end of this talk you'll understand a bit more why. In terms of the variations across the UK, you can see here that there is a down regulation in lactose non-persistence individuals, and lots of studies across the world have actually looked at this, and it does vary in age depending on the different studies that have been done, and it also depends on people's ethnic origin. Looking at this across the globe, you can see that the down regulation of lactase production leading to malabsorption of lactose increases in sort of the southern African countries and also within Asia. And you can see that the European countries where there's a lot of lactase persistence, which I'll talk about in a minute, is where you have much lower levels of downregulation of lactase production. In terms of lactose intolerance frequencies, again, the darker the blue is where you have much higher frequency of lactose intolerance, again in the southern half of Africa and also in Asia and also in South America. Where you have the lighter colors, this again represents where lactose tolerance is better, and you can see this across Europe and also in America. So if 35% of humans persistently continue to produce lactose after weaning, they should easily be able to consume milk and other dairy products into adulthood. And this is what we call lactase persistence. And it's very common in European countries and in North America for this to be quite common. And there are other places within the world where it's much more difficult to consume these dairy foods after weaning. So lactase non-persistence is known as the sort of the normal situation with that gradual downregulation, and it's actually lactase persistence that is which is more unusual. So there are different types of lactase non-persistence. There's congenital lactase deficiency, which is extremely rare, and then the primary lactase deficiency, which occurs in about 70% of the population, ranging from 5% in British to 90% in the Asian communities. And we find that in irritable bowel syndrome, there's a huge variability across the whole population in terms of who can tolerate lactose and who can't. And what I was saying earlier about lactose non-persistence and lactose malabsorption, not all people have symptoms of lactose intolerance. There's also another type, which is the secondary lactase deficiency, which is where the lactase in the brush border decreases for a temporary period, as in celiac disease or gastroenteritis, but it will be returned to its usual levels after restoration of the gut mucosa has recurred. So lactose malabsorption, as I mentioned, is the incomplete hydrolysis of lactose and the presence of unabsorbed lactose in the colonic lumen. Whereas lactose intolerance is where you get the occurrence of gastrointestinal symptoms due to this unabsorbed lactose in the colonic lumen. And it's very much dependent on self-reported symptoms after lactose digestion. But as I've already said, not everybody with lactose malabsorption has lactose intolerance. If we look at this in a bit more detail, you can see that in normal lactose digestion, you consume lactose here, and the lactase enzyme is here in yellow, and this cleaves the lactose into glucose and galactose, which gets absorbed into the bloodstream. If someone is lactose intolerant, they're not producing any lactase, so the lactose continues through the gut, and in the colon it gets fermented by the bacteria, and this leads to short-chain fatty acid production and gases, and this is what will cause the irritation and the signs of intolerance or GI symptoms. There are lots of tests that can be used to measure lactose malabsorption. There are direct tests, which are potentially quite invasive, and there are the indirect tests. The most common one that we would use is the breath hydrogen test, and this is where we measure hydrogen and methane after a load of lactose, and we measure the gases for a period of 3 hours. Lactose digesters don't increase their breath hydrogen level because there's no lactose that's ending up in the colon, and it's a really useful test to use. Usually you might use 25 grams of lactose, but you can use up to 50 grams, and it's variable depending on which protocol and which country you might be in. But the breath hydrogen test is probably the most well-known test that we might use. What happens when you have lactose is it passes through the small intestine, and if it's not being absorbed, it will get fermented by the bacteria, leading to hydrogen production in the large intestine, and that hydrogen is what we're measuring in the lungs, because it's gone through the bloodstream and it's exhaled in the lungs. What's involved with a breath hydrogen test? So you have to follow some very strict pre-test instructions. No antibiotics or prebiotics for 4 weeks, no bowel prep for 4 weeks, no laxatives or antidiarrheal medication for 3 days, avoidance of test sugars, fermentable sugars for 24 hours. So this would not only include lactose, but also other fermentable carbohydrates, so things like fructans and fructose and galacto-oligosaccharides. And the subjects have to fast for a period of 10 hours as well. They also must avoid chewing gum and not smoke before the test. And different protocols will vary from one centre to another, but these are the sort of the basic protocols that you really need to follow to make sure that you're getting a true result when you do a lactose breath test. So what happens is that you have after the 10-hour fast, you have the baseline breath sample and then the ingestion of the test liquid. So as I said, it would either be 25 grams of lactose. We also use lactulose as a sort of control test because lactulose is a carbohydrate that's not absorbed in the human gut, so it will always end up in the colon, and you will always be able to detect gases in response to that. And that gives you an idea about how long it takes for that carbohydrate to actually reach the colon. Usually you'd do the test with 250 mils of fluid, and at 15 to 30-minute intervals after the ingestion of the test liquid, you would then have breath samples taken at intervals until about 3 or 4 hours, depending on how long it takes for that carbohydrate to pass through the gut. You'd then also record symptoms, because this is a really important thing to do to assess whether someone's having any intolerance signs. And as I mentioned, protocols do vary. So the breath sampling intervals might vary, the diagnostic criteria, the gases that might be measured might vary. So you might just do hydrogen, or you might do hydrogen and methane. The thing with breath tests is that you can get false positives. And the reason for this is that first of all, you might have a large dose above the tolerance of lactose, and this will lead to a positive test result inducing lactose intolerance symptoms in lactase non-persistent individuals and lactase persistent individuals. So it may be that the dose of lactose is much too high and they're going to get some malabsorption anyway. The test environment itself is also very controlled, so it doesn't really give you a true indication of what's going on in normal day-to-day life in terms of normal tolerance to lactose as well. And with the issue around the bacterial fermentation, some people produce hydrogen and other people may produce more methane depending on their gut microbiota. And these gases can also be absorbed into the bloodstream and rapidly dissipate, and you don't really get increases in the hydrogen and methane levels. So it's really very dependent on these different things that might be going on. To confirm a diagnosis of lactose intolerance, the best way to do it is to exclude lactose from the diet until the person gets symptom resolution, and then to challenge with lactose to induce symptoms, and then reintroduce lactose to the personal tolerance threshold. And this is really what we would call the gold standard method that we would be looking at for confirming that diagnosis. In terms of managing lactose intolerance itself, we only restrict lactose if it's absolutely necessary. And we would only restrict it initially for 4 weeks. We would monitor symptoms following this and then reintroduce lactose to tolerance, increasing by 1 gram of lactose per day, and adjust the dose gradually over time. What's important to remember is that dairy foods are a very good form of a source of calcium, and if you reduce lactose in if you're worried about calcium intake, it's still very well absorbed from milk despite this lactose intolerance. So if someone has lactose intolerance, it doesn't mean that they're not absorbing their calcium. And I think that's a really important thing to remember. In terms of sources of lactose in the diet, it naturally occurs in milk and milk products. And then, as I mentioned at the beginning, it's commercially added to certain foods as well as a bulking agent. It's also used as fillers in pharmaceuticals, and it might be used to increase the color in baked goods. And in terms of the average human diet, we find that it's around sort of between 7 and 12 grams per day. And so that's the sort of the intake that you might find in a Northern European person, whereas across the world it will vary hugely depending on that presence of lactase non-persistence. Sources of lactose. So what's really interesting, not all dairy foods are really high in lactose. Milk is definitely one with a high lactose content. So if you had to have a 250 ml glass of milk, it would contain about 15 grams of lactose. A yogurt pot of about 200 grams would contain 8 grams of lactose. And then there are a variety of other foods that have varying levels, so things like custard, ice cream, and certain cheeses and chocolate. But some cheeses are very low in lactose, and the reason for this is that during the maturation of cheese, much of the lactose gets converted to lactic acid, and it no longer becomes a problem because it doesn't need to be broken down by the enzyme lactase. So if it's in the form of lactic acid, it's no longer an issue in terms of developing symptoms. Also, very high fat dairy products contain very, very little lactose. So things like butter, cream, and cream cheese as well. In terms of the different types of milks, so semi-skimmed milk, whole milk have very similar levels of lactose if you're thinking about cow's milk. But if you were to have something like condensed whole sweetened milk, this is much higher, so 12.3 grams per 100 grams. And skim milk powder has a very high level, 52.9. Evaporated milk, 8.5. Goat's milk is slightly lower than cow's milk, and human milk is higher, and sheep's milk is slightly higher than cow's milk. So in terms of suitable foods for someone who has lactose malabsorption and they have lactose intolerance symptoms, you would usually restrict milk and milk products so that they don't have more than 4 grams of lactose at each sitting. And this is usually well tolerated. But many people during that sort of early stage when you cut down on lactose, they're very keen to restrict lactose right down to see if they can get rid of their symptoms. But in the longer term, I would say that someone with lactose intolerance should usually be able to tolerate 4 grams of lactose per sitting. So there are lots of alternative lactose-free milks, and you have got the sort of lactose-free milk where it has been exposed to lactase, and that's still a dairy-based milk, but it doesn't have any lactose in it. And then you have the plant-based alternatives to milk, so things like soya, rice, oat milk, nut milk, almond, hazelnut, macadamia nut, hemp, coconut, and quinoa. The issue with a lot of these milks is that they're very low in calcium, so you want to make sure that you're advising people to take a plant-based alternative that has been supplemented or fortified with calcium. So in terms of lactose tolerance, over the course of the day, you may find that if people can tolerate 4 grams of lactose in one sitting, they can probably tolerate up to 12 to 15 grams of lactose over the course of the day. But it really is very dependent on lactase activity. In terms of small intestinal adaptation, there's no evidence to suggest that over time you're going to get a change in terms of the small intestinal lactase production. So what we do know is that the intestinal microbiota is really important, and I'll mention that a little bit later on. In terms of transit time, perhaps that might have some kind of impact. So if you're having a meal that's slowing down transit time, so perhaps a higher fat meal may actually help to slow down transit time and improve lactose absorption. You may find that probiotics will help improve the tolerance, and lactose itself can be a prebiotic. And in terms of that individual perception of symptoms, perhaps that's a really important thing to be thinking about as well, because it's important to remember that one person may find that, you know, they malabsorb lactose, but they have very mild symptoms, but they just accept that as being normal. Whereas someone else may find that they have very mild symptoms, but those are really quite debilitating. So it's very much dependent on the individual tolerance of those symptoms. Ways that you can actually improve lactose intolerance are carried out through various different ways. So if you were to just have lactose on its own in a glass of milk, you may find that that person doesn't tolerate that very well. So mixed meals can improve tolerance quite a lot, because you're helping to dilute the impact of the lactose within that particular meal. Cereals and increased energy content will help delay gastric emptying. So if gastric emptying is delaying, it's hopefully reducing the amount of lactose that's passing into the small intestine at any one time, and thereby helping to improve the lactase impact on the lactose that's passing through the gut. Supplemental lactose is a consideration as well, and some people may take supplemental lactase when they have a high lactose intake, but it's not always effective. Food temperature may also affect transit intolerance, so that's something to be aware of. So very hot food may make transit faster, and also very cold food. So if that's the case, you may find that the lactose is just passing through the gut too quickly and ending up in the colon, and thereby it's increasing that impact of the bacterial fermentation. So other things to be thinking about would be, as I mentioned earlier, the calcium is one of the major nutrients in milk, and issues with calcium and vitamin D could lead to challenges with bone mineral density. Dairy-free alternatives may be supplemented, but they're often more expensive, and the calcium itself is less bioavailable. Reintroduction and compliance of lactose is really important, because why avoid something unnecessarily if it's a really good nutritionally balanced food that you could incorporate into the diet. However, many people choose not to have any dairy in their diets these days, and it's important to make sure that, if they're restricting dairy for reasons of lactose intolerance, then perhaps they can actually improve that intake up to their tolerance threshold. And many people with lactose intolerance don't actually have lactose malabsorption. They just feel that they are very symptomatic. Perhaps it's other things that are causing symptoms, and it's not just lactose, and they're suspecting lactose is the cause of their problems, but actually it's other fermentable carbohydrates. And there's a big overlap between lactose intolerance and irritable bowel syndrome. So I'm going to have a little look now at some of the management strategies that we might be thinking about there, and then we'll also mention a little bit on the prebiotic effect of lactose as well. So in terms of lactose intolerance symptoms, things like abdominal pain, bloating, flatus, diarrhea, bulgorygmy, which is noises in the tummy, nausea and vomiting, and constipation, have all been described as lactose intolerance symptoms. These are also symptoms of irritable bowel syndrome as well. So it's really important to think about that when you're thinking about, is it lactose or is it actually something else? And if we look at the diagnostic criteria for irritable bowel syndrome, you have to have recurrent abdominal pain, at least 1 day per week in the last 3 months, associated with 2 or more of the following. So it's related to defecation, or associated with a change in frequency of stool, or associated with a change in the form of the stool. And for IBS, you have a variety of different subtypes depending on the stools themselves. So this is here on the right. I won't go into too much detail today about the IBS subtypes, but this is based on the Rome 4 IBS criteria. So dietary triggers in IBS are very common. It's reported in up to 90% of people, and 2/3 of patients with IBS initiate dietary restrictions. About 45% of patients with IBS describe lactose intolerance, and diet is the mainstay of treatment strategies. So in the UK, we developed BDA guidelines, and we came up with this algorithm for IBS management through diet. And we have these first line strategies where you would first of all do your clinical assessment, looking for other signs of organic causes for symptoms. So ruling out celiac disease, for example, ruling out inflammatory bowel disease, taking a really good medical and family history, looking at weight, BMI, and symptoms, and trying to subtype the IBS symptoms. And then we would advise on healthy eating and lifestyle, checking for food intolerances, especially milk or lactose, and then also assessing dietary fiber, fluid, fatty foods, caffeine, spicy food, and alcohol intake. This is the first line treatment strategy, and we would advise on this and review patients. And if there isn't any benefit, we would then move on to the second line strategy, which is the low FODMAP diet. I'll talk a little bit more about that in just a moment. And with the low FODMAP diet, we would then again advise review. If there's adequate symptom improvement, we would then reintroduce high FODMAP foods back to the personal tolerance threshold of that patient. FODMAPs are fermentable oligosaccharides, which are things like fructans and galacto-oligosaccharides. Fructans come from things like wheat, onion, and garlic. Galacto-oligosaccharides come from beans and pulses. The disaccharide is lactose, so this is where lactose comes into the whole issue around the low FODMAP diet. The monosaccharide is fructose, which comes from things like honey and fruit juices. And then the polyols are things like sorbitol, which you might get in some fruits and vegetables, but also are found added to things like chewing gum and other sugar-free sweets and things like that. What happens is that FODMAPs increase small intestinal water, and studies have shown that things like fructose and lactose will increase that water content within the gut, and that will lead to increases in the motility through the lower part of the gut. In addition, other FODMAPs, fructans in particular, have been demonstrated to increase colonic gas production in a similar way to the way that we described lactose getting fermented in the large intestine as well. And there's some really nice studies that have been done looking at both of these in terms of the water production and the increased gas production. And these MRIs show the increased gases in response to a high fructan diet. So you can see here where you give fructans, you get this much higher level of colonic gas volume. So we know that FODMAPs will impact sort of the motility and the water content and the gas content within the gut. And there have been lots of studies now looking at the low FODMAP diet, and this systematic review and meta-analysis shows that if you compare the low FODMAP diet to other control diets, the low FODMAP diet improves symptoms far better. And if you look at the this systematic review and network meta-analysis, it shows that the low FODMAP diet is actually far more superior to other dietary treatments, and you can be 99. There's a sort of a 99%. So you can be a 99% improvement. You can be 99% sure that the low FODMAP diet is going to be superior to these other dietary treatments. And this was a really good study, so it's definitely worth having a read of this paper here. We did some work that was led by one of my colleagues who did her PhD some years ago, Heidi Staudacker, where we looked at nutrient intake, diet quality and diet diversity in patients with irritable bowel syndrome and the impact of the low FODMAP diet. And what I wanted to show you here was that the lactose intake that we measured at baseline was around sort of 9 grams per day. And on a low FODMAP diet, this reduced down to about 4 grams per day. And in the sham or habitual diets that we had used as comparatives to the low FODMAP diet, it didn't really reduce down significantly from that sort of 8 or 9 grams. So you can see that lactose does get reduced in the low FODMAP diet during that restriction phase of the diet. What's important to remember about the low FODMAP diet is in clinical practice, it's not just about FODMAP restriction, which is only what we advise for 4 to 8 weeks. And it's during this period that we reduce down the FODMAP load, which is shown here in blue. So we reduce that right down here. And the red line here shows the symptom level. And you can see that by reducing FODMAPs, you're actually reducing symptoms. And then the important aspect of the low FODMAP diet is the reintroduction phase, where we challenge with different FODMAPs at different points, some of which will induce symptoms and some won't. And that will lead to the longer term personalization stage, where we advise patients to have a slight increase in their FODMAP intake, and this will help to keep their symptoms under control for the long term. In terms of that long-term personalized approach, we did some research looking at the low FODMAP diet, and we found that it does improve symptoms in the long term following that reintroduction and personalization stage. And one of the challenges that we found about reducing FODMAPs that it would reduce the luminal bifidobacteria abundance, but in the long term we find that this is restored to its usual level after 12 months if you follow the personalized low FODMAP approach using that reintroduction and personalization in the longer term. So in terms of restoring the luminal bifidobacteria, we do find that if patients are advised on the different stages of the diet and they're not just on FODMAP restriction for the long term, it's a much healthier option for them for their gut bacteria. Indeed, in this study, we also looked again at the lactose content of the diet, and you can see here that at baseline, these patients had 9 grams, and this was restored back to 9.9 grams of lactose at the end of the 12 months. So this is when they had actually been through that restriction phase, the personalization phase, and found that they'd identified which FODMAPs they needed to avoid. And interestingly, for these 18 patients, there was a significant reduction in the long term for their sorbitol intake, but not for any of the FODMAPs. It was only 18 patients and it wasn't powered for that particular outcome. Indeed, the other thing that was important here is that their calcium intakes were maintained in the long term as well. So despite FODMAP restriction in the short term, in the long term, their calcium intakes weren't being impacted. Now, finally, I wanted to just mention the prebiotic effect of lactose. And I'm not going to go into any detail here, but I just wanted to introduce that Jan Gertz is going to be presenting on this in just a moment. And it's really interesting to think about how lactose can actually induce colonic microbial adaptation, and it can also help to reduce symptoms of lactose intolerance. So I'm not going to say anything more about that, and I will keep you on tenterhooks for that. So just to start to sum up, when do we restrict lactose? So if lactose is a reported problem food, then we would assess symptoms during a breath test. We don't always do breath tests these days. Sometimes we might actually, through patient choice, just look at restricting lactose and look at the ability to comply with the lactose restriction, and then retest tolerance using the gradual reintroduction process of lactose to identify how much they can tolerate in their diet. And I mentioned earlier that you can usually tolerate up to 4 grams at each sitting. So having an amount that would be 12 to 15 grams per day would not be unreasonable. So in conclusion, I've talked that lactose is a very unique and fascinating carbohydrate, which is only found in mammalian milk. Lactose malabsorption is common and present in lactase non-persistence and lactase persistence. The diagnosis of lactose malabsorption can be very challenging, and lactose intolerance is clinically important, and there's that overlap that we might have with irritable bowel syndrome. And the management of lactose intolerance. So we think about reducing lactose dairy products. Most people will tolerate some lactose, as I mentioned. Be aware of dietary calcium restrictions and what impact that might actually have in terms of bone health. Think about encouraging lactose in mixed meals. Think about gastric emptying, what foods help to slow down gastric emptying, what impact there might be with transit time. And also, as I mentioned, consider the IBS impact as well. Are there other dietary restrictions that may be more appropriate? And then lastly, thinking about that prebiotic effect. And I'll just leave you on that note so that you can be really engaged when you're listening to Jan's talk in a moment. Thank you very much for listening, and I just want to acknowledge my teams, my clinical team and research team at Guy's and St Thomas's and King's College London. Thank you very much for your invitation.